Welcome back. Our next speaker is Dr. Charlotte Goldfein, who's an emergency medicine doctor at the Brigham, and she's an expert in medical toxicology, and will talk to us about poisonings and intoxications.
Thank you so much for the introduction. So today we'll be talking about poisonings and intoxications, what a nephrologist needs to know. I am an emergency medicine physician and medical toxicologist at Brigham and Women's Hospital, and I help run the residency toxicology rotation, as well as the site fellowship director for the Harvard Medical Toxicology Program. I don't have any disclosures. And so through this talk, we'll be discussing and having you recognize the key nephrotoxins. We'll discuss and help you understand specific indications for dialysis and toxicity. And then we'll review the role of the nephrologist in key high-risk toxicities and renal-specific considerations. So to begin, we'll go through a case. This is a 35-year-old man who comes into the emergency department. He appears intoxicated and is minimally responsive. EMS found the patient with a suicide note and a bottle of antifreeze. On exam, he's afebrile, tachycardic, tachypnic, and has a blood pressure of 120/60. We get some labs, and you can see some key highlighted in red. So a bicarb of less than 5, an anion gap of 23, pH on a VBG of 6.9 with a lactate of 8.9. And as you can see here, between both the measured and calculated osms, there's a large osm gap of 70. And some urine calcium oxalate crystals. And nephrology is consulted. So where to begin? Well, to start, why does this talk matter for nephrologists? Well, as you probably know, toxins are frequent causes of acute kidney injury and often require dialysis. Poisonings can be common in both the ED, ICU, inpatient hospitalization, and nephrologists are often brought in for toxin removal, acid base, and electrolyte management, as well as assessing renal injury or failure. And there is a large overlap between all of the care we do between our interdisciplinary teams. And so it's really important for nephrologists to be aware of the considerations from the ED, ICU, and toxicology team. Now, the kidneys are extremely vulnerable to toxins, not only by direct toxicity or deposition of toxins into the kidney, but they also serve as a route of elimination. This dual role means we often see renal injury even when the toxin isn't inherently nephrotoxic. For example, if the patient can't eliminate a certain medication, it may cause toxicity because of the accumulation of that toxin. And so this diagram here from Goldfrank's Toxicologic Emergencies textbook shows some of the mechanisms and areas where you may see key toxins affect the kidney. And we'll talk about some of these specific examples as we go through. Now, one of the important reasons why nephrologists often are involved in these cases is to discuss indications for extracorporeal removal. The reasons why the methods by which we can do this are a few. The most common, and one you'll probably be asked about a lot, is for hemodialysis. There is also charcoal hemoperfusion, but that use has really declined with the improvements and abilities to dialyze most toxins by hemodialysis. We may also do forced diuresis, which is using increasing fluids to help excretion through the normal processes of the kidney. And then urinary alkalinization, which we'll talk about in more detail when we talk about a specific toxin. Now, the most common reasons why we use hemodialysis are in cases of lithium, ethylene glycol, salicylates, and acetaminophen. We really try to avoid hemodialysis if the risk of hemodialysis alone would cause harm, or there are other effective and less invasive treatments, which is why you may be wondering, why does acetaminophen show up on this list? And that's because we do have a much safer and less invasive way of treating acetaminophen toxicity with N-acetylcysteine. But as we'll talk about, there are some specific indications why it may still be indicated. Now, we typically use hemodialysis for patients in cases where the responsible xenobiotic is removable and the patient either fails to respond to comprehensive supportive care, the normal route of elimination is impaired and high morbidity and mortality is likely. And then additionally, hemodialysis can also correct acid base and electrolyte abnormalities such as metabolic acidosis, hyperkalemia, and volume overload. An important unwanted effect, though, of hemodialysis to be aware of is that it also can remove the therapeutic drugs and antidotes. And so doses of these, especially antidotes, may need to be increased if we are doing hemodialysis, either during it or immediately after. Often we'll have to increase the frequency with which we give the antidote. A very common example of this includes fameprazole, and as we go through our cases, you'll see why that is. Now, when we think about which toxins or which xenobiotics can be removed by hemodialysis, there's a few characteristics that we will consider. One is the size. So we really want small size, but depending on the type of extracorporeal removement that you're using may depend on the size. And so I put this chart here so you can see for which indications a certain size would matter. But for all of the ways in which we will do removal, what we really want are a few key characteristics. One is the volume of distribution to be small, so less than 1 liter per kilogram. And that's because it means that then the xenobiotic is in the serum and can be removed by hemodialysis. We also want low protein binding, and there are some exceptions to this, especially in overdoses. For example, valproic acid is a highly protein-bound compound, but it can be removed in overdoses by dialysis because when there's a large amount in the body, that protein binding will become overloaded, and there will be a much larger amount of free xenobiotic in the serum that can be dialyzed. And then also, we want to reserve this for when hemodialysis will enhance the clearance compared to endogenous clearance by a factor of 2, or if there's overall low endogenous clearance. And then we want these xenobiotics also to be very water soluble and have a low lipophilicity to be able to be removed by the hemodialysis circuit. And so a lot of this is really going to depend on the pharmacokinetics in overdose, which may be different from what we expect from the normal pharmacokinetics. But overall, these are kind of the key guidelines, but as you know, there are exceptions to every rule. And so we'll talk about the specific toxins that you should be aware of and will most commonly interact with. Now, the other consideration is, should we be doing intermittent hemodialysis or continuous renal replacement therapy? For almost all toxins or medications where we're going to be doing dialysis, intermittent hemodialysis is the preferred situation. And usually this will be performed over 4 to 8 hours. The goal is really to increase the clearance of the drug or to help correct the toxicity as rapidly as possible, since most of these are acute toxicities that we're talking about. Now, with CRRT, this can be used, but the blood flow and effluent flow are lower than those administered during intermittent techniques. So the achievable xenobiotic clearance is lower. However, what they lack in removal rate can be compensated by longer administration because you can perform it without interruption for sometimes several days. You can also perform it in places like the ICU, so especially for critically ill patients or depending on personnel staff, CRRT may sometimes be the route that needs to be used. Other times may also be to prevent something called rebound, where after hemodialysis, because the xenobiotic will shift into the serum again from the intracellular compartment based on the gradient. Once it's removed by dialysis, you can sometimes get this rebound effect. So what we will sometimes do to prevent that is do hemodialysis followed by CRRT to prevent that. But overall, our goal in most cases is to increase the rate of removal. And so that can be most readily done with the intermittent hemodialysis. And so that's going to be usually the preferred route. Now, to help come up with some of these guidelines or when the specific indications in a specific patient, there is this XTRIP work group, which can be really helpful to look up to see if dialysis is indicated in a specific case. XTRIP is the Extracorporeal Treatment and Poisoning Work Group, and it's a collaboration of experts from diverse specialties. So it includes clinical toxicologists, nephrologists, pharmacologists, critical care, and emergency medicine physicians. Um, and what they did is publish evidence-based recommendations for toxin removal. It covers greater than 20 toxins and is a great guidance for when to initiate dialysis and poisoning, as well as guidelines for stopping dialysis. So it can be a really great starting point. And they have both on their website the indications, but also links to all of their publications with longer recommendations. So you can look into the exact toxin and why the recommendations are made. But especially for some of the guidance that will go through, some of the toxins that will go through, there is really strong guidance. So specifically for lithium, ethylene glycol, methanol, and salicylates. Now, besides hemodialysis, nephrologists play a very important role in poisonings, especially when we think about electrolyte and fluid management, renal dosing of antidotes, monitoring of acute kidney injury, recovery, and preventing further renal injury. And then, of course, a lot of these cases are very sick patients and require multidisciplinary communication. And so as a team, we can help take care of these patients together. So going back to our case, you get a lab draw of ethylene glycol, and you see that the level is elevated to 277.3 milligrams per deciliter. So what would we do with this case? Well, this is our specific toxin, ethylene glycol, which is one of the important toxic alcohols. What you see with ethylene glycol is very similar to ethanol intoxication. Patients are going to look intoxicated. They will often develop nephrotoxicity, but you can also see hypocalcemia, severe metabolic acidosis, and even cerebral edema. The labs you're going to look for are an elevated serum osm gap, as well as a large anion gap acidosis and an elevated lactate. So a normal osm gap is around 2 to 11. But when we start to see gaps greater than 10 to 15, that's concerning for a foreign osmotically active substance in the serum. It's important, though, to think about the timeline of when you're reviewing the labs on this patient, because what will happen first, they're going to have that parent compound, the ethylene glycol, and that's the osmotically active agent that is going to cause the osm gap. As the patient starts to metabolize that, that will shift into the glycolic acid or oxalic acid. That is the toxic metabolite that is no longer osmotically active, but will cause the anion gap. And so you can see this shift over time from ingestion. Your osmolar gap will drop, but you will see this increase in anion gap. And so it's really helpful to look at these both in context of which ways they're trending, not just one or the other in isolation. And so the other important toxic alcohol to be aware of is methanol, which is going to be metabolized to formic acid and cause much more ophthalmologic toxicity, but also can cause nephrotoxicity and may need to be dialyzed as well. But much more commonly, we see ethylene glycol, which is metabolized to form oxalic acid and glycolic acid, which are the toxic metabolites. Both of these toxic alcohols are metabolized, again, similar to ethanol, by alcohol dehydrogenase into their toxic compounds. You'll see renal crystal injury caused by the toxic metabolites of ethylene glycol. The key really is early recognition and treatment with alcohol dehydrogenase inhibitors, which are either going to be fameprazole or ethanol. Occasionally, in severe cases, dialysis will be indicated as well. The important part is that dialysis can clear both the parent compound as well as the toxic metabolite, and it can also correct the acid-base disturbance that we see. And so the specific indications for hemodialysis and ethylene glycol are when there's a suspected ethylene glycol ingestion with an osmol gap greater than 50 and an acidosis. Also, when there's renal failure and organ toxicity, which can include coma and seizures, an ethylene glycol concentration greater than 50, or severe metabolic acidosis. And especially in the metabolic acidosis, when it's severe, the alcohol dehydrogenase will not, inhibitors like fomepizole will not correct the acid base status. And so, especially in late presenters where the toxic metabolites have already formed, this may be important. And then fomepizole is dialyzable as well. So if it is being given, you'll need to increase the frequency to every 4 hours during hemodialysis. And then hemodialysis should be continued until the anion gap is less than 18. The ethylene glycol concentration is less than 25 milligrams per deciliter, and acid base abnormalities are corrected. So next we'll go through a second case. This is of a 38-year-old man who has a past medical history of bipolar disorder and presented for increasing tremors. He was working during the heat wave and his place of work had no air conditioning. He first noticed that he had this tremors in his bilateral hands and seemed to be worsening as he continued to work. And he felt these generalized muscle spasms. On exam, you note horizontal nystagmus. He's tachycardic, has increased tone throughout with tremors in the extremities as well as in the tongue. And labs are concerning for a sodium of 129 and a creatinine of 5.9. So you get one more lab, and the lithium level comes back at 4.2 millimoles per liter. So this is a case of lithium toxicity. Now, lithium is a really interesting medication. It works very well, but unfortunately, it has a very narrow therapeutic window. And so we can see three different types of toxicity with lithium. There can be acute toxicity, which is where a patient takes an overdose. Predominantly, those will present with GI symptoms such as nausea and vomiting. But more commonly, we will see chronic toxicity, such as this case where a patient takes lithium, has some kind of an injury to their kidneys, like dehydration. So, very common in these summer heat waves. And they will present with predominantly neurological symptoms, like this tremors, altered mental status. And then you can also see acute on chronic toxicity, which is where a patient who normally does take lithium then has an acute overdose. And those will be a mixed presentation of both the neurological symptoms and the GI. Now, unfortunately, in these chronic and acute on chronic toxicities, the symptoms don't correlate with the serum levels. So even at lower serum levels, they may clinically be more intoxicated. And that is because a lot of the lithium will live within the CNS and not within the serum. And so the level may not look very elevated despite them having a high CNS level. Now, some other important symptoms about lithium to be aware of are that it can also cause a chronic tubulointerstitial nephropathy. You can see hypothyroidism, hyperparathyroidism, hypercalcemia, Epstein's anomaly, leukocytosis. Silent is one we worry about, which is the syndrome of irreversible lithium effectuated neurotoxicity, which is basically that the tremors or altered mental status, coma, doesn't reverse despite decreasing or reversing that lithium toxicity. It's not really clear exactly why that happens, and there unfortunately is no clear indicators to know when that happens, but it's often why when patients have severe symptoms, we will push to try to get them treated as soon as possible. And then nephrogenic diabetes insipidus can develop within weeks of patients being on lithium. It occurs in about 40% of patients. And what happens is it inhibits the transport of sodium through the amiloride sensitive epithelial sodium channels. Lithium has a twofold higher affinity for this channel and becomes intracellularly concentrated. This then inhibits the magnesium dependent G proteins, leading to decreased cyclic AMP in the distal tubule, and you get reduced aquaporin 2. Therefore, the distal tubules become resistant to vasopressin. And so the treatment is most commonly going to be IV fluids, and we'll talk about the considerations for dialysis. Lithium toxicity, especially chronic toxicity, is going to be common in patients who have CKD, acute kidney injuries, or in the elderly. And the fluids are going to be the first step in treatment. We really want to keep IV fluids at 1.5 to 2 times maintenance. And we want to use normal saline because of that sodium exchange, because by using the sodium chloride, you can increase your excretion of lithium in the distal tubules. Now, indications for dialysis are going to include a concentration greater than 5, a concentration greater than 4 with AKI or CKD, a decreased level of consciousness, seizures, or life-threatening dysrhythmias at any lithium concentration, or if it's going to take longer than 36 hours to reach that lithium concentration of less than 1. Salicylates are another really classic presentation that we see that can cause a mixed acid-base disturbance. We can see both acute or chronic toxicity that can manifest as confusion, tinnitus, and hyperventilation. Salicylates directly stimulate the respiratory center, producing a respiratory alkalosis, and then they uncouple oxidative phosphorylation, leading to that metabolic acidosis. Um, Salicylic acid is a weak acid, and so we do use urinary alkalinization because what this does by getting the urine pH up to a pH of 7.5 or greater, we keep the salicylic acid in its ionized form, which will prevent reabsorption and increase excretion of the salicylic acid. Dialysis is very effective, especially in chronic toxicity or in patients with renal disease. So you can see here the certain indications, but especially in patients who have altered mental status, respiratory distress, or new hypoxemia or severe acidosis, it's very important to do dialysis. Acetaminophen is the most frequent pharmaceutical agent that is involved in human poisonings. Usually it causes hepatotoxicity because it saturates the glucuronide and sulfate conjugation pathways, and you get this toxic metabolite called N-acetylparabenzoquinone or NAPQI. Now, there's 3 aspects why nephrologists might get involved with poisonings, and that's extremely large overdoses because you can see an early metabolic acidosis due to mitochondrial dysfunction and impaired oxidative phosphorylation, even before the hepatic transaminase activities reach their peak. You can also see an AKI that can occur in about 2% of all overdoses due to acute tubular necrosis. That can occur also in severe injury. And then there are some indications for hemodialysis, mostly in these extremely high concentration levels, so greater than 900, with altered mental status, metabolic acidosis, and an elevated lactate, or if N-acetylcysteine is not available with these extreme overdoses. Next, we'll discuss metformin-associated lactic acidosis. Thankfully, this is a very rare presentation, but it does have a pretty high associated mortality. It will usually occur to a predisposing pathophysiological condition that leads to supertherapeutic accumulation of metformin, which will then lead to hyperlactatemia and metabolic acidosis. So things like renal injury, hepatic or heart failure, shock, critical illness, sepsis. And you can also see it after an overdose. And so what you'll see is profound acidosis and shock. The role of dialysis is somewhat debated because there is pretty good endogenous clearance of metformin. However, because of the severe metabolic acidosis, dialysis can also help more rapidly clear the acidosis. And so it can be useful, especially CRRT in unstable patients. And we'll close with the last case. This is a 28-year-old male who was found unresponsive at a party. EMS said bystanders reported that the patient was using cocaine and alcohol. He came in confused, agitated, diaphoretic, with dilated pupils. He has muscle tenderness in the calves and thighs, but no focal neurological deficit. His labs are concerning for a creatinine of 3.2, which is up from his baseline of 0.9. And he has a creatinine kinase of 112,000 and a potassium of 6.5. And so this is a case of cocaine-induced rhabdomyolysis, which led to an acute kidney injury, hyperkalemia, and metabolic acidosis. So with this patient, IV fluids are going to be really important. Also treating the hyperkalemia. Often this will occur because either the vasoconstriction from cocaine, but they can also get hyperthermia and agitation with muscle hyperactivity and seizures, which can lead to rhabdomyolysis, and therefore they can get an AKI, which can be common. It can also be caused from hypotension from severe toxicity, the myoglobin deposition, or direct injury. Dialysis may be indicated in patients who have refractory hyperkalemia, severe acidosis, or volume overload. Fluid resuscitation really is going to be key in these cases, as well as managing the electrolyte abnormalities. And so a few take-home messages from this talk that I hope you'll go home with are to know some of your dialyzable toxins, especially ethylene glycol, methanol, lithium salicylates, metformin, and in select cases, acetaminophen. Nephrologists are key. Your expertise in fluid and electrolyte optimization, renal dosing of antidotes, and acute kidney injury recovery monitoring is critical to patient outcomes. And don't forget to leverage your expert guidance. X-Trip consensus recommendations can be a really useful tool to help make some timely and evidence-based decisions on initiating dialysis. And here's a few resources for you. If you happen to be at Brigham and Women's, we do have a toxicology consult service that we're always happy to discuss cases. But no matter where you are nationwide, we have the Poison Center who can help you, and you can talk with poisoning specialists or toxicologists through dialing this number. And a few references as well. And with that, I'd be happy to take any questions with the remaining time.